Science Center seminar series. My name is Megan Lane Fall, and I'm the Executive Director of PICE. It's my great pleasure to introduce our visiting speaker, Dr. Jennifer Callaghan-Koru. Dr. Callaghan-Koru is an Associate Professor at the University of Arkansas for Medical Sciences in the Department of Internal Medicine, who has a background in public health. Dr. Callaghan-Koru's work focuses on the design and evaluation of community-based interventions for maternal health, neonatal health, and child health, and studying the social determinants of health. She's done a lot of work in low-income countries and is also the co-founder of the Implementation Science for Maternal Health initiative with Rebecca Ham, based at the University of Pennsylvania. There are many more accolades and many more qualifications I could tell you about Dr. Callaghan-Koru, but I want to turn things over to her so she can present her work to you. So welcome, and the floor is yours.
Thank you so much. I just want to check my sound is okay and the slides are showing for everybody. Great.
Your sound is great and slides are showing.
Perfect. I'm really excited to be here with you all today. I think Penn does incredible work in implementation science. Dr. Lee Paul said there are some quality improvement folks on the call today too, which makes my heart very happy. I think we need more interaction between implementation science and quality improvement, and more quality improvement folks at the table, partnering with us, working together to help solve our evidence to practice gap problems. And so that's the approach I'm going to be talking about today. And so I want to start with a little bit of a personal introduction of how I came to do the work that I'm doing now, make the case for why integrating implementation research in large-scale quality improvement initiatives is an important way forward, and then give some examples from my work working with perinatal quality improvement initiatives, specifically perinatal quality collaboratives. So in terms of my background, I'm currently an associate professor at the University of Arkansas for Medical Sciences. My background is in public health. I have a PhD in public health, and I'm trained as an implementation scientist and a health services researcher. Most of my work has been focused on maternal and child health. I also have several public health practice and service roles that help enable the work that I'm going to describe here. So that's why I share them, because I think they're really important. One is that I'm the co-founder and director of evaluation and research for the Arkansas Perinatal Quality Collaborative. And I'm also on the steering committee for the Maryland Perinatal Quality Collaborative. And then, as Dr. Lane Paul mentioned, I've been really interested in helping to advance implementation science in maternal health. And to do that, I co-organized the group Implementation Science for Maternal Health with Dr. Rebecca Ham at Penn, and also work with her and a colleague at University of Michigan on a special collection for the implementation science communications journals on maternal health. So to tell you a little bit how I ended up feeling really passionate about integrating implementation science with quality improvement work. So as a doctoral student, I was really interested in helping programs maximize their public health impact. And the way that I saw to do that, based on what I was learning, is through program evaluations. So I trained with a really great group in program evaluation at Johns Hopkins School of Public Health, the Institute for International Programs. And I continued to do similar work as a faculty member after finishing my training. And the more program evaluations I worked on, the more I saw a recurring pattern, which was that, especially with really large-scale programs working in the global health context, in national health systems, we had a really hard time saying whether the program worked or not, because what we saw is the programs weren't implemented well. They weren't implemented as intended. And that happened often enough times that I thought, this seems like the problem to solve. We need to, in order to maximize the public health impact of programs, we need to improve implementation. And so that's when I started transitioning to, doing what's defined as implementation research. I started doing it under program evaluation umbrella without knowing about implementation research, but that's when I started learning about implementation research and applying those models and frameworks and ways of looking at things to public health programs and quality initiatives. And at one point, I had a really fortuitous meeting with the then medical director for maternal and child health at the Maryland Department of Health. And I was telling her about my research interests, and she introduced me to the Maryland Perinatal Quality Collaborative, which was a program that was funded out of her office. and was doing was doing that practice work of improving care, and she suggested that I talk to them about, ways to work together in order to answer some of these implementation questions in maternal health. And that one meeting changed the course of my career. And so that's one of the things I want to share, because especially those of you who might be interested in those of you who might be early in your career and you're kind of figuring out your research trajectory, what you're most passionate about, what are the areas where you can make a difference, is that those meetings that you have that you don't know where they're going to lead could have a really profound impact. So explore, talk to people, find out what's going on the ground in terms of clinical care programs, whatever area you're interested in, and explore those relationships, because they could lead you to a career trajectory that you never anticipated. And what that meant for me is that I partnered with the Maryland Perinatal Quality Collaborative for several years. And then I had the opportunity to come to Arkansas, which was a state that didn't have a perinatal quality collaborative yet, and helped to found it. And that was a really exciting opportunity for me, because I saw such ability to build in data systems, ability to answer questions that we had about how to do quality improvement in maternal health more effectively, and also really feedback the results of that work to the labor and delivery units and the birthing hospitals that were engaged in quality improvement work. So now I'll talk a little bit about kind of this vision for integrating implementation science with large-scale quality improvement. And most of what I'm going to talk about is in a paper that's published in Clinics in Perinatology. The title's here, Integrating Implementation Science with Quality Improvement to Improve Perinatal Outcomes. So if you're interested in a bit more information about it, that would be a good resource. So starting with some definitions, I think these are probably definitions that you're all very familiar with. So I'm not going to read them, but I do want to spend a little time characterizing what I see as the major distinctions between implementation science and quality improvement. And as I see it, implementation science really prioritizes generalizable knowledge, and in order to obtain generalizable knowledge, using really rigorous research methods. Whereas the focus in quality improvement is achieving local improvements in patient outcomes or efficiency. And kind of how you get there is a bit less important than getting there. And that's why there's these iterative approaches, PDSA cycles, small tests of change in order to reach that goal of local improvement in patient outcomes. And I think one helpful way to think about this is the distinction is, what happens if you don't see a change? What happens if you don't see an improvement? In an implementation science study, if you've used rigorous methods and you've answered the question, does this implementation strategy work? And your answer is no, I don't think that would be viewed as a failure. That would be viewed as an important contribution to knowledge, generalizable knowledge. Whereas in a quality improvement project, if at the end you see you didn't improve patient outcomes in the way that you intended, that would more be viewed as a failure, and you'd go back to the drawing board and do it again. So that's kind of how I conceptualize the distinctions between the two fields and how they're oriented differently. Now, as we saw from the definition for implementation science, it really came about to solve a problem, that problem being the difference between what's the best evidence of interventions that are most effective and what's routinely done in clinical practice. So the evidence to practice gap, and the idea being that with implementation research, we could find out the causes of this gap and the ways to close it. But I think what we're increasingly recognizing has happened in practice is that we're generating a parallel evidence to practice gap. And what I mean by that is, just as research evidence about the most effective interventions doesn't automagically become a part of routine care overnight, the research evidence about effective implementation also isn't automatically being applied routinely. I see the primary end users of evidence from implementation research as quality improvement leaders and managers in health services organizations. And I think these folks are doing the work of implementation in their organizations, but evidence published in implementation science and similar journals isn't usually presented or disseminated in a way that's easily transferable for them. So without a concerted effort to promote the uptake of implementation science evidence, we're creating this second evidence to practice gap. So I think the question before us is, how should we think about this reality of a parallel evidence to practice gap, and what can we do about it? So first, I think we can recognize or take a moment to appreciate the irony. But really, we should have anticipated this scenario, because there are so many examples in healthcare and just generally in life where when we try to fix one problem, our fix creates another problem. And that's why, as a best practice, quality improvement initiatives include a balancing measure. So that it's a measure that's intended to monitor unintended consequences of whatever changes you're making. Second, I think we can also consider why this parallel gap has emerged. And I would argue that the key reason is that the research approaches and implementation science have by and large been modeled after clinical research approaches. And those are the approaches that have produced the original research to practice gap. So there's this nice quote describing this quandary: we cannot solve our problems with the same thinking we used to create them. This has been questionably attributed to Albert Einstein. I did a little looking into it briefly. It seems he wrote a variation of this sentiment, but not in such a quotable fashion. So the internet refashioned it. But regardless, I think it's a good summary of the root causes of one of the root causes of this problem, the parallel evidence to practice gap. And what we may need then is a different way of thinking or different approaches to generating evidence that don't occur outside of practice, or implementation practice in this case. So a solution that I see is this implementation, research, and practice partnership. And obviously, a lot of implementation science takes place in practice settings. Most of it does. But what's not always there is the ability to feed back the results of implementation research directly into that practice work. And there are a couple of solutions to this. And I'm going to talk about one, and then I'm going to talk about the one that I've been focusing on. So one solution that's been proposed is implementation labs. And I think this is a really great idea. And there's good models of where implementation labs have been used really successfully. In implementation labs, if it's not familiar, if you're not familiar with the concept, there's a nice definition from a commentary in The Lancet that they involve close collaboration between health systems delivering implementation strategies at scale and research teams. Implementation laboratories provide an opportunity to kickstart the field by ensuring that scholars meet both applied and scientific goals of understanding what works better and why. So that's an approach that has become more and more common. There are a couple of barriers that I see to implementation labs. One is it can be difficult gaining buy-in from health system stakeholders. A couple of reasons for that are that might lead to slower change processes, so incorporating implementation research in those. It also involves a greater data collection burden than people are used to. And with the emphasis on implementation labs often being on one health system, because that's where it's most feasible to create a partnership, there's also limited generalizability to other health systems, potentially. So a second solution, beyond the one health system implementation lab, is large-scale quality improvement initiatives. And I'm going to share an example of what I mean by that. But the way large-scale quality improvement initiatives can solve some of these problems, organizations that are participating in large-scale quality improvement initiatives have already committed to change. They're agreed to undertaking the work of changing clinical practice. In large-scale quality improvement initiatives, we have the opportunity to provide external support and resources to help participating organizations make those clinical practice changes. So that ameliorates some of the slowing down that we might see in the change process. Large-scale quality improvement initiatives often have a data submission or data collection requirements. So that's a part of the expectation of participating. Organizations that are participating are already expecting to be doing that. And then they typically engage facilities across multiple health systems. So that solves some of our generalizability problems when we're not looking at just one health system, but we're looking at standalone community hospitals, as well as academic medical centers and hospitals that are participating in a variety of different health systems. So with that background, I want to present some examples from perinatal health area where I've been working. And these examples come from work both in Maryland and in Arkansas, and we're supported by great teams of collaborators that listed here. Some of it's been funded by NIH, as well as the Center for Disease Control and Prevention and HRSA. So in maternal health, there are several large-scale quality programs or initiatives. Maternal health has been getting a lot of attention in the most recent years because we've seen outcomes much worse than our peer nations, and also that are steadily getting worse. And so there's a real recognition that there needs to be improvement in maternal health outcomes, and one of the important ways to do that is improving the quality of maternal health care and standardizing care. So some of the initiatives that are ongoing to support that work are development of consensus maternal safety bundles. And this is taking place originally through the Council on Patient Safety and Women's Healthcare, and now through the AIM program. There's state perinatal quality collaboratives, which every state is encouraged to have, and state perinatal quality collaboratives typically bring together the birthing hospitals in the state to work on a common quality improvement topic over a period of time. And this work usually follows a quality improvement collaborative model similar to the IHI Breakthrough Series. And then there are additional support sources of support for maternal safety bundle implementation from federal funding agencies, including HRSA and through the AIM program that's funded by HRSA at ACOG. On the right, you'll see an example of one of those maternal safety bundles. This is the obstetric hemorrhage bundle. And the maternal safety bundles include evidence-based or evidence-informed practices to standardize clinical care and better address causes of severe maternal morbidity and mortality, to recognize them more quickly and to manage them more effectively. So in the last decade, perinatal quality collaboratives, with the support from these different programs, have grown to encompass almost every single state in the US. And the last estimate that I had from the AIM program is that close to 2,000 birthing hospitals are participating in a perinatal quality collaborative. So you can see, the reach is really broad. And this is an opportunity to look across one health system, but include a variety of facilities that are participating in quality improvement programs. So then we have these perinatal quality collaboratives with a partnership for implementation research. What can we study? So here I have the IPARIS determinants framework for implementation, one of the several determinants frameworks that's commonly used, as well as the Proctor outcomes framework. And the outcomes framework, I would say, is typically addressed somewhat well in the existing plans for quality improvement collaboratives and the data that they're expected to collect, so that it's not introducing something that looks new or different, although we can increase the rigor of it. But what is, could be new or different is really systematically looking at these other determinants: context, innovation, process, and recipients. And I would argue that we can study all of these things, and we can learn a lot from studying them in perinatal quality collaboratives. For the innovation, we can think about in these recommended strategies in maternal safety bundles: what's their acceptability? How are they being adapted? What's their real-world fidelity? In terms of context, thinking about birthing hospitals, we can investigate volume, rural, urban setting, whether they have a teaching program or not, what state policies they're impacted by, how those contexts affect implementation. In terms of the recipients, thinking about the physicians and nurses who would be implementing evidence-based practices, what's their capability, opportunity, and motivation to make these changes, depending on what change they're being asked to make. And then in terms of process, at each birthing hospital that's participating, internal process, who's leading it and who's engaged in implementation, and what strategies are they using. Similar to any quality improvement collaborative, there's, it's a bit of a nested implementation. So there's this external facilitation from whatever organizations coordinating the collaborative with the support and coaching that they provide. But then each hospital that's committed to participate is really responsible for deciding internally how they're going to go about the work. And that's intentional given that facilities are often starting in different places in terms of what they've already implemented. They have different contexts and resources. And the intention is for each facility to try to make the best decisions for how to effectively improve care in their setting. An example of a quality improvement goal that's really common for perinatal quality collaboratives is reducing primary cesarean birth. You can see from these figures here first that cesarean delivery rates have increased a fair amount in the US from their low in the 1980s to kind of plateauing after an increase now from around 20% to over 30% now. You probably know that cesarean birth is the most commonly preferred surgery in the United States. And what's interesting is that there's a lot of variability between hospitals in terms of what their cesarean delivery rates are. And so this suggests that, it's not necessarily differences in the patient populations that's causing these increases in cesarean delivery rates, but it's differences in clinical practices. And why it's important to reduce cesarean delivery rates, especially for primary births, so the first birth to a woman, is they carry both short and long-term risks. And the long-term risks are the ones that are most concerning. If we're thinking about a woman who's having her first birth by cesarean, she's likely to have later births by cesarean. And for every cesarean birth that she has, the risk of really severe complications, such as placenta accreta, increases in a bit of a dose response fashion. So major national strategy to support reducing primary cesarean birth rates is implementation of the AIM patient safety bundle on safe reduction of primary cesarean birth through perinatal quality collaboratives. And as I mentioned, I first started partnering with perinatal quality collaboratives in Maryland when I was a faculty member at the University of Maryland, Baltimore County. And I worked with them on conducting some implementation research to support their cesarean collaborative, which took place between 2016 and 2018. In Maryland, there are 32 birthing hospitals, and they had 31 of those hospitals participating. And those hospitals committed to implement practices from this maternal safety bundle. If you look at it really closely and disaggregate, there's a lot in the bundle that they could be doing. So there are 26 practices that at that time were organized by 4 R's: readiness, recognition, response, and reporting or systems learning. With an implementation scientist hat on, some of what's in these bundles are actually implementation strategies, not necessarily clinical practice changes, but the way they're presented to the hospitals is these are the quality improvement changes that you can make. So working with the Maryland Collaborative, I helped to evaluate the outcomes of the work in the collaborative, both overall and then looking at digging deeper into the implementation that occurred at hospitals. This graph shows the overall changes in cesarean birth rates across the collaborative in Maryland. There you'll see 3 lines. The dark blue line is the cesarean delivery rate for all births. The hashed red line is low-risk primary births. So those are nulliparous term, singleton, vertex pregnancies, and those are the patients that should have the lowest need for a C-section. And then the dotted green line are the cesarean rates for NTSB or low-risk primary births after an induction of labor. So looking here, you'll see that there's decrease from our baseline to end line for all of these measures, particularly the dotted green line, which is the cesarean birth rate after inductions. And this looks like a success, right? The Maryland Perinatal Quality Collaborative met its goal to reduce primary cesarean deliveries. But if we dig a bit deeper and we look at the hospital level, This graph shows the change in cesarean delivery rate for NTSB inductions, where there was the biggest improvement, hospital by hospital. And the blue lines show a hospital where the rate went down, and the orange lines show a hospital where the rate actually went up during the collaborative period. And we had 12 hospitals that had an increase in their cesarean delivery rate for NTSB births. This is actually consistent with what has been reported in other studies of perinatal quality collaboratives. The most research has been done within California's collaborative. It's the first and largest collaborative that's had several evaluations of its work. And they've reported similar things. Around a third of hospitals participating in a perinatal quality improvement collaborative don't see the improvements that they had a goal of making. So how can we understand what's going on and why some hospitals are falling behind in this quality improvement work? So one thing we can look at is the innovation. We know in the bundles, there's a lot of things that they could do. They have the ability to choose what they're working on. How are their choices impacting what's happening in terms of their patient outcomes? Because it's a little complex to study 26 different things with different patterns in every hospital in terms of adoption, we looked at it by area of the bundle. And what we asked is, if a hospital adopted more than the median number, so there's a median number of practices from that bundle that were adopted, if they were above average, more than the median number, was that associated with lower C-section rates? And what we saw was that was not the case for readiness, recognition, and prevention, and reporting and learning. Hospitals that did more in that area did not have lower C-section rates. But it was the case for response. And thinking about that more carefully, the interventions in the response category of the bundle are the most focused on standardizing clinical care. So that seems to be where it's important to focus, is on those interventions that are recommended that standardize clinical care from this study. Another thing that we could look at to understand what's going on differentiating hospital performance is process. How did they go about the work of quality improvement, implementing practice changes? And what we saw also is that there was a lot of variability in how many practice changes hospitals made during the collaborative. There was also variability in where they started. So in this figure, you see the dark shading for each bar is the number of recommended practices that a hospital reported already having in place before the collaborative started. And then the hash bar represents the number of practices that they implemented during that 2-year collaborative. So this is all self-report. But you can see even within different levels of care, so a level 1 hospital is basic maternity care, level 3 and 4 hospitals are able to have higher volumes usually and deal with more complex cases. There was variability within each of these levels. The median number of new practices that hospitals implemented during the collaborative was 4. And the range was really wide. So some weren't able to implement any new practices during the collaborative, even though they committed to participate. And the largest number was 17 that was reported. And so one thing we did is we asked them during the first year of the collaborative what additional implementation strategies that they were using to help support their quality improvement work. And we asked specifically about 15 strategies that are in the ERIC list that you might be familiar with. We only selected the strategies that seemed, that were within the control of one labor and delivery unit. And what we found is that there were 3 strategies that were associated with faster adoption in the first year. And those, there were 6 strategies, but 3 of them were really focused on planning. And so that was interesting to me. First, that for several of these planning strategies, only 1/3 of the hospitals reported using them, but also that they were significantly associated with adopting more practices. So if we look at the first one, conducting a local needs assessment, if a hospital reported doing that, which about half of hospitals did, then they, on average, adopted 2 more practices than hospitals that didn't do that during the first year of the collaborative. And in some of the qualitative work we did with the nurse leads or physician leads at these hospitals, it became clear, how this was operating and why this was the case. So talking to one nurse leader who had a lot of quality improvement training, was really well prepared to lead a quality improvement initiative, she said, I chose to follow Cotter's 8 steps to change. We looked at our baseline data, created a sense of urgency. We had a work plan, and we utilized the work plan throughout. We looked at what was low-hanging fruit, what we thought would get us the biggest bang early so that we could hopefully demonstrate some success. This is a really intentional approach to implementing the maternal safety bundle for cesarean deliveries. But here's an example of a hospital that wasn't in a place to follow such an intentional approach. So we asked, how did you go about deciding what to do first? And the nurse leader says, honestly, we were not very organized about this. And I honestly can't remember the answer to that question, how we decided what to do first. I know that when we met, our challenge with a lot of these things were policy driven and the obstetricians were not on board. And as a follow-up question, I asked, did you have a formal plan? And the answer was no, we really did not. So very, very different profiles of within a hospital, how they're going about doing the quality improvement work. And so both quantitatively and qualitatively, we can see the importance of planning. So with the implementation research partnership, we don't want to just learn from the quality improvement initiatives, but we want to feed those learnings back to support the quality improvement work. So how did we do that? With the collaborative that I'm working with now, the Arkansas Perinatal Quality Collaborative, we created planning tools. So we know that planning is important, but we also know that not every hospital is prepared to put together a plan. They don't have quality improvement training. They don't have maybe support from a quality and safety division in the hospital. And so we put together several tools to help them think through what do they already have in place, what changes could they make, and which ones would go the longest way in order to improve outcomes in their hospital, in this case, cesarean delivery rates. Also knowing that standardizing care was really important, but the bundle doesn't come with off-the-shelf tools. We created tools that were aligned with the clinical guidelines for these best practices that could be used as off-the-shelf resources for hospitals that wanted to standardize care. So we have an induction of labor checklist based on the guidelines, as well as a pre-cesarean communication tool for huddles or peer review. So now I'd like to talk a little bit more about the work in Arkansas and how we've been developing the systems of the Arkansas Perinatal Quality Collaborative in order to facilitate implementation research and incorporate those findings back into the Perinatal Quality Collaborative's work. And in case you're not familiar with quality improvement collaboratives, in general, perinatal quality collaboratives, I'll provide a little bit of detail about what it looks like. This is the structure of our Perinatal Quality Collaborative, and we are coordinated by the University of Arkansas for Medical Sciences, which is currently the only academic medical center in the state. We have a steering committee that has representatives from professional associations, health systems within the state, community representatives, patient representatives. And we also partner with the Arkansas Department of Health in terms of policy and data access. In terms of the supports that we provide to participating hospitals, we have quality improvement coaches who are nurses with quality improvement training, have a lot of perinatal experience. We do, as a group, learning cycles where we have expert presentations every quarter around important topics or practices that could be implemented. And then we have report outs by each hospital once a quarter. And we're currently doing that on a rotating basis. So a group of hospitals presents one month and then the other set presents the next month in between our learning sessions. And then we also do a lot of data collection and reporting to support their work. Our first initiative was also on reducing primary cesarean because Arkansas is one of the states with the among the 10 states with the highest cesarean delivery rates. We have a goal of trying to get 70% of our hospitals at the Healthy People 2030 goal, which would be a low-risk primary cesarean delivery rate of 23.6%. We started this work with recruiting hospitals to participate. It's the first perinatal quality collaborative in the state, so that took a bit of time introducing the concept, what would be involved in participating, what would be the benefits of participating. And we had a kickoff meeting in July and have been going through our learning sessions. We plan for supporting hospitals to do the implementation work through the first half of 2025. And then we'll be planning for sustainability and the next initiative. Here's a look at our quality improvement coaches and how they've divided up the hospitals according to different regions of the state. They have monthly or quarterly meetings with every hospital as well. And our data systems are what really allow us to help to answer some research questions as we go about this work. So we receive data from the Arkansas Department of Health for patient outcomes. And we also collect information from participating facilities, some on patient outcomes, but mostly about their implementation outcomes and their implementation processes. We collect, clean, process, analyze that data, and we provide it back to the hospitals in benchmarking reports, and we also submit it to the National Alliance for Innovation on Maternal Health Data Center. And I would say that these data systems look very similar to most perinatal quality collaboratives. What we're doing a little bit differently than the typical perinatal quality collaborative is we have enhanced data collection for implementation research. So in the quarterly implementation status reports, where hospitals are telling us what work they've been doing, what practice changes they've made, we collect a couple of different things. So we ask about their internal processes. How often are they meeting? Who's coming to the meetings? We ask about, for an individual practice change, how much time are they spending in each stage of that change? When did they start planning to make this change? When did they, begin implementing it? And when would they consider it fully implemented? And we're also asking about their interactions with peers and what practices they adopted from their peers. I think the extent to which there's really that collaborative learning in perinatal quality collaboratives is a really important question. How can we foster the collaborative learning, and what benefits does it provide or not? We have, during the facilitation calls, the QI coaching calls, we have facilitation notes that capture the barriers and facilitators at each facility. And then we also, for this initiative, done provider surveys, and we're hoping that there'll be ability to do that for future initiatives as well. One of the reasons we did a provider survey for this initiative is there's a nice measure of labor culture that was developed by researchers at the California Maternal Quality Care Collaborative that's now been used in a variety of perinatal quality collaboratives that can help hospitals gain insight into how their physicians and nurses think about best practices for supporting vaginal birth and practice changes to reduce cesarean delivery. And because there was a compelling case to implement this measure, we also included some implementation research measures that are validated scales from the implementation literature. So I want to give a sneak peek for some of what I think some of the most interesting findings that we're seeing so far from the data that we've been collecting for the Arkansas Perinatal Quality Collaborative. And one of the questions that I find really compelling is the question of teamwork on the unit. From the qualitative work I did with the Maryland Perinatal Quality Collaborative, teamwork really came through as very important in labor and delivery, maybe more so than other divisions in the hospital, but particularly for things like the practices that are recommended for reducing cesarean delivery rates. They involve a lot of interprofessional collaboration, and the extent to which there's good collaboration and teamwork on a unit is really likely to impact the success in implementing those practice changes. So I wanted to see how we could better understand this teamwork culture and how it impacted implementation. And so in the survey that we did with participating hospitals that opted into it, we collected information about teamwork and unit readiness for implementation using 2 validated scales. For teamwork, we used the Safety Attitudes Questionnaire developed by AHRQ that has 6 items. And for unit readiness for implementation, we used the ORIC, which many of you are probably familiar with, and that's a 12-item validated scale. Both are Likert scale measures that have a maximum average score of 5. And what I was particularly interested in is seeing if we could tease out what's really a unit level effect and what's an individual level effect. Because you can imagine, if I'm a pessimist, my individual rating on the teamwork scale might be lower. as would my individual rating on the implementation readiness scale. So this, because I tend to focus on the problems, I'm going to rate both of these things lower than somebody else on my unit. And using an analysis approach of group mean centering of predictors, we're able to try to tease out what's the unit level effect, like what's real in the unit versus the individual level effect of how one particular person sees things on the unit. So we had 27 hospitals participate in the survey. And I would say this is one of the limitations of integrated implementation research in quality improvement, is that we really want to balance the burden of data collection. This is the quality improvement work takes priority over the implementation research. And so we made this voluntary and allowed hospitals to opt in or opt out. The good news is 27 hospitals out of our 34 participating at that time did opt in. We had 501 providers take the survey, 48 obstetricians, 9 family physicians who deliver babies, 4 midwives, 22 anesthesiologists, 336 labor nurses, and then the other category tended to be nursing leadership. 92% of the participants were women, and the median number of years of experience was 8 years of experience, and that ranged from 0 to 55 years. And looking at unit average scores, the average unit level score for teamwork was 3.8 out of 5. And we use these visualizations when we shared the information with our hospital to kind of indicate green being, on the positive end of the scale, above neutral, your agrees and strongly agrees, and oranges being on the more negative end of the scale with poor perceptions of teamwork or implementation readiness. So the average teamwork was 3.8, and the unit average ranged from 3.2 to 4.5. And then for organizational readiness, the average was 3.6, and the unit average scores range from 3.5 to 4.1. And again, this is averaging those Likert scale questions that are measured on a scale of 1 to 5. And when we did the modeling where we separated out the teamwork predictor from the individual and the unit level. And the way we did this again is we included in the model the average for each unit as a predictor, as well as the individual score with the unit average subtracted out. So it's the individual teamwork score that's unit mean centered. And this is a multi-level model result that controls for clustering at the hospital level. It also has including control variables for clinical role and years of experience. And what we see is both the individual mean-centered score and the unit average score have a significant effect on how respondents are rating organizational readiness for implementing change. And given that this is a maximum score of 5, you could see these coefficients as being somewhat large. So for the unit average teamwork score, if the unit average response increases 1 point, so going from agree to strongly agree, then their organizational readiness for implementing change score would increase by 0.776. So it's just, it's under 1. It's not a 1-to-1 correspondence, but it's a pretty strong effect. And also the individual score had an impact. So there is that impact of how someone sees things on, if they're it might be that they're a glass half full or glass half empty person. If I see teamwork as positive, I'm also going to see implementation readiness as positive. But regardless of the effect of how I see things as an individual, there is a unit level effect for that unit average score. So how do we feed this back into the quality improvement work of the collaborative? We provided benchmarking results to every hospital. So this is a mock result for our Arkansas General Hospital, not a real hospital in Arkansas, to show you what it looked like in terms of what we were providing them, both the collaborative-wide average scores compared to their average score and the unit level responses for them. So after presenting the approach and these examples, I want to share a couple of thoughts of what you might take away for your own work. So first, some considerations that might be limitations of integrating implementation research into large-scale quality improvement. First is that quality improvement initiatives tend to operate in a much faster timeline than research funding. So I can give you a story when I first wrote a NIH grant to study this with the Maryland Perinatal Quality Collaborative. It was during the first year of the collaborative. And that small grant, R03 grant, just missed the funding cutoff. So I had to resubmit it the next year. And by that time, the collaborative had ended. So instead of looking at the outcomes of the collaborative, I had to totally rework the proposal in order to look at the sustainability of the collaborative. And those are kind of difficult changes to have to make. And not really, the funding models aren't designed necessarily, at least the research funding models aren't designed for this type of work. Second is that the research goals really are and should be secondary to the improvement goals. So I gave the example of, when we did the provider survey, we made that optional. We didn't want burden of data collection to discourage people from participating. And that's the case with all of the data we collect. I do think it's an advantage that participating in large-scale quality initiatives, hospital teams already have the expectation that they're going to be submitting data, that's an important part of the work. We are able to build in new data collection into the existing system, so it doesn't feel like it's as much of a burden. We're able to be really responsive. We have quarterly reports. If something emerges as a really important issue, we're able to add in a couple of questions at that quarterly report. And because we're not asking for a separate data collection encounter, I think it feels a lot more manageable to the hospitals that are participating. And then just summary thoughts, I think strong implementation research really requires scale. The more variety of participating organizations that we can include, the more generalizable results that we have, and it really increases our ability to answer important questions. Large quality initiatives can provide that scale and the variability in terms of context of participating organizations. And I think that integrating implementation research findings into quality initiatives is a really powerful way to prevent that second research to practice gap, to make sure that those who could benefit from our implementation research findings are receiving those findings in really actionable ways, practical ways for them. So by working with quality initiatives, we know what types of tools are helpful for them, what they're looking for to support their work, and we can translate our implementation research findings into tools that are useful for them and get them to them as quickly as possible. So that is what I wanted to share with you all today, and I think we have plenty of time for questions. So Dr. Lane-Fall, how do you usually moderate the questions?
So if you can stop sharing your screen, then I'll put everybody, let's see, I'll remove your spotlight and then we'll see people. So thank you very much. I'm doing lots of virtual clapping for you, and we've got a great turnout here, and I see some friendly faces here, including Dr. Ham and Dr. Ashcraft, and you've got some applause here. Dr. Ashcraft has a question for you in the chat. So she wants to know if you looked at which hospitals had robust QI infrastructure. Some hospitals use Six Sigma, some use Lean. They have all of their various approaches to upskilling people in QI. So what can you say about that?
Yeah, there's a lot of variability. And it's both, what's the preparation of the nurse leaders and physician leaders or the quality safety team on a unit, and also what resources the hospital offers as well. So some hospitals would have the quality and safety unit that would come in and design their QI program for them and give them a structure for how to do it. Whereas we have small community hospitals where there's maybe one or two people on the nursing staff that are put in charge of this work. They don't have any quality improvement training. They might have very limited experience doing quality improvement work. And then they're much less equipped to hit the ground running.
That makes sense. Now, one of the questions that I get asked a lot is the difference between QI and implementation science, which I think you covered really nicely. A related question is, what should QI folks know about implementation science from a training perspective? And I guess the reciprocal would be, what should implementation science folks know about QI? So curious what insights you have about not just the partnership, which is really powerful, but also kind of the content, the knowledge basis?
Yeah, that's a really good question. I think first, kind of the rigorous and standardized methods for collecting data is really important and the design of a study is really important in implementation research. And it's something that we tend to set in stone at the beginning. We don't want to change it over the course of a study, whereas quality improvement work might change things along the way as you're experiencing success or not experiencing success. So I think that that's one major difference in approach. And the small tests of change and quality improvement really encourage adaptation, changing things iteratively throughout an initiative or a program, whereas we're really taking more of a set, keep it the same, keep it standardized so that we know that we're measuring things in valid ways, or we think we are in an implementation research study. So that would, how that can help implementation researchers and quality improvement folks work together. I think implementation researchers need to think about the burden of the data that they're asking for and try to really balance it and make a case for how it's going to be useful. So if we didn't have the labor culture survey to ask about that in the survey that we did with providers, I don't think we would have asked to do a survey just on the implementation readiness scales, because it wouldn't have felt as useful to them as the labor culture survey, which, it's really, I think, intriguing to them of understanding how are my providers thinking about different evidence-based practices. So it's really trying to kind of balance the needs and perspectives of achieving change, but also measuring things in a really rigorous way so that we are confident in our answers to our research questions.
That's great. Thank you. Feel free to put questions in the chat, everyone. Otherwise, I'm going to keep peppering Jennifer with questions. One of the questions that I get asked is, what's the role of the implementation science in the learning health system? And you described really nicely this structure that sort of sits on top of multiple health systems where you have QI coaches and then you have your implementation science expertise, but that same structure is not reflected in the health systems themselves, where they have variable QI infrastructure, but usually there's something.
Mm-hmm.
There probably isn't an implementation scientist or practitioner. So should there
Mm-hmm.
be? What do you think about that?
I think what's really powerful about the work, the way we've structured the work, is that feeding findings back into the units that are doing the quality improvement work as useful tools. So I think implementation research in a learning health system just for implementation research sake isn't as exciting as implementation research for improvement. So the extent to which you could have an implementation research team in an organization that considers itself a learning health system to answer questions and have the ability to maybe make changes in the EHR or have an orientation towards providing useful tools to the clinical units that are doing the quality improvement work would be what I would think would be most useful. I don't know if that answered you have very good, tough questions. I don't know if I answered them as well.
Yeah, I think that was great. I'll ask you one more question and then I'll ask Dr. Ham, because I know she works with you closely in the IS4MH group. What's the case for these various hospitals to participate in the collaborative? Because I could imagine, they've got to free up people to be able to participate. There is a cost to that because they can't do other things. So can you talk a little bit about how institutions become a part of this partnership and kind of the rationale that they state for being a part of it?
Yeah, that's a really good question. So there's a couple of external things that help motivate people, but I would say there's actually really strong intrinsic internal motivation, particularly from the nurse leaders who are leading a lot of this work. Because they're in management positions, they have a bit more time in order to do quality improvement work than some of their clinical colleagues. Some hospitals have also really great clinical champions that are really passionate about the work as well. I think there's something really rewarding about the collaborative nature of everybody coming together, being on a call with all the other hospitals in the unit, in a state, usually for a perinatal quality collaborative, a sense of camaraderie and friendly competition. But there's also really tangible benefits. So in Maryland and now in Arkansas, we've replicated a listserv that hospitals that are participating in the Perinatal Quality Collaborative are subscribed to. They send questions on a weekly basis to each other that aren't necessarily related to our current initiative, but just an issue or clinical questions. How do you deal with this? How do you deal with that? Do you have a policy already for XYZ? So they get a lot of tangible benefits from participating through that as well. And there's really good sharing, a lot less competition than you might expect from hospitals and different health systems, a lot more sharing. And then in terms of external incentives or motivations, that vary state to state. So in California, the state that's had the most demonstrable success with perinatal quality collaboratives, the insurers align their incentives with the goals of the perinatal quality collaborative. So when they were doing the cesarean initiative, they selected hospitals that had rates that they considered too high and said, if you don't get your rates down, then you're not going to be able to participate in our plans. And so there's a really strong incentive to participate for those hospitals. I don't think most states have that same level of stick in addition to carrot. The federal government through CMS has created a new birthing-friendly hospital designation. And it's still, the operationalization of it isn't totally clear, but one of the criteria for meeting birthing friendly is to participate in a perinatal quality collaborative. So I think, right now there's no financial incentives tied to it, but there could be in the future. And I think certainly hospitals want to typically want to check off those quality improvement designations.
Yeah, that's really helpful.
Good camaraderie. Please.
Yeah, no, I think that I missed the beginning of your talk, so I didn't ask any questions because I didn't want to cover things that you've already covered. But I think that you, at first, thank you so much for talking here today. It's always nice to see your face. But I will say that, the point about insurers is just so critical in this piece in terms of quality collaboratives. And I'm sure that, relays across different multidisciplinary types of these collaboratives, but it's really driving in our space. I think that the collaboratives that are either funded or very much supported by insurers see the most significant success, both in able to collect data, be able to distribute data, and to be able to have coordinated sort of implementation efforts and study those efforts across people. And, here in Pennsylvania, we are funded by, our quality collaborative is funded by a lovely foundation. However, that ability to have that same effect is more limited because of the fact that it's like a charity foundation that sort of funds it, and our insurers are not as involved in that process.
That's a really helpful insight. And I agree with you. I think this applies, across fields outside of maternal and perinatal health, that using the power of collaboratives and using the power of the purse with the insurers is a really important incentive. Jennifer, you have a question in the chat from Victoria that says, is there any way for the general population to find out a hospital's C-section rate? Or is it as heavily guarded as they imagine it is?
No, there are. Oh, geez. And Rebecca, you might be able to answer this better. So I think hospitals that participate in Leapfrog share their C-section rates.
Yeah.
I don't think CMS is sharing it yet. Are there other sources?
So the U.S. News and World Report maternity ranking that people are there's a lot of reasons why people are very anti this reporting system that I am not the ideal person to speak on, but you will find other people within our Amethyst program, Megan, who can speak on this more substantially, which is that, there is not really any balance based on the type of population that's being taken care of or the risk factors coming into pregnancy when reporting on a lot of these metrics, which provides a lot of challenge. And hospitals were being ranked, based on some of these things, but you can find some things like around C-section rate within that maternity ranking for U.S. News and World Report.
And in Maryland, they have that global payer system. So Maryland had more quality data available, and some other states might have similar data sources that are state specific. I think California also maybe required hospitals to report it. And that's where we'd like to get is more transparency in reporting. The data access can be a little bit challenging. So for our data that we received from Arkansas Department of Health, we had to get a data use agreement with every single hospital to satisfy the Arkansas Department of Health agreement to share data with us. And, in order to be able to at least collect the information and evaluate in a de-identified way our collaborative outcomes, feed it into the national reporting, we agreed not to publicly share it. So there are challenges kind of with balancing people's comfort or organizations' comfort level with participating in evaluation activities like this, and the benefit of at least giving it back to them without sharing it publicly. But it's certainly something that patients can ask their providers too. What's your organizational C-section rate? What's your C-section rate as a provider? How do you support vaginal birth? For example, do you offer vaginal birth after cesarean, for example?
Those are great points. And I think it also calls out the importance of the patient and community perspective on these efforts, these improvement efforts. And I think I remember you saying that there is patient level involvement in your collaborative, which is great.
Yes. That is really important. And for this initiative, we were able to find 2 patient representatives from the Accreta Foundation. So 2 Arkansas residents who had placenta accreta after multiple C-sections. They recorded some testimonials for us, which are really powerful about, kind of what's the impact on a patient of having multiple C-sections and having this major complication. And I think that really helps kind of increase motivation of the individuals participating in the collaborative to hear a story like that.
That's great. So I'll ask you one more question. When do you decide that this part of the collaborative is done? You talked about I think it was the baseline and the end line was the terminology you used in one of your graphics, but when do you turn your attention to something else, and how do you try to maintain the gains in one area as you might start to focus more intensely on something else?
Yeah, that's a really great question. I think every state PQC does it differently, but it seems to be most common that you start out with an initial commitment. So you're saying, we're going to do this topic for 1 year, or maybe we're going to do this topic for 2 years. And then you get to the 1 year mark and assess people's interest in continuing it. How much progress have they made? Do they want to continue it? But I think it's a really insightful question also because hospitals are able to move at different speeds. And when one hospital is ready to finish, another hospital's not. Maybe they were changing their EHR in the first 6 months of the collaborative and really couldn't do anything. And so one of the results I didn't present is in Maryland, when we looked at the sustainability, we saw that actually on average, hospitals implemented more practice changes after the collaborative ended than they did during the formal collaborative period. And I think that's because it takes a while to kind of build up speed. You're rolling that rock, starting it rolling down the hill. In the 2 years that you're in the formal collaborative initiative period, you're picking up speed as you go, but also that motivation to continue to make practice changes stays after the initiative changes. But then you're competing with the new initiative, so I think it's a little bit tricky. And maybe in an ideal world, you could stagger it according to where each hospital is, whether they're ready to move on to something new or whether they need to continue with the same work for longer, but that's not how it's typically being done now.
So Shelby's got a question for you. And they say, I know that respectful care was a later addition to some of the AIM bundle recommendations. Can you share any examples of how equity and respectful care were integrated in perinatal quality care collaboratives?
Yeah, so that's a great and really important question. So for the study of the Maryland Collaborative, that was not an addition to the bundle yet. For the work that we're doing in Arkansas now, it is a part of the bundle. I think one of the first things that people tend to do is look at their data disaggregated by race to see where they are. And that's not easy for every facility to do. So just being able to do that, and that's one of the benefits of the data that we're getting from Arkansas Department of Health, is we are getting patient level data. so that we can disaggregate by race, by rurality, by insurance type, and do that easily across the collaborative and for each individual hospital so that they can see where they are. And then, some of the other things that are recommended in that section of the bundle are things like shared decision-making, trainings on respectful care and implicit bias. And one of the things that we saw in the Maryland Collaborative is that for the trainings that are recommended, there weren't really easy to access off-the-shelf tools for hospitals to use. So they either had to find a training or create their own, and that delayed implementing those trainings. So one of the things that we're planning to do, but we haven't gotten to yet, is at least for this area, we did create an off-the-shelf training on an e-learning platform that provides continuing education credit related to strategies to support vaginal birth. But for the next step, we want to provide a shared decision-making and respectful care trainings to make that easier. And since they are across most of the bundles, should be a long-standing resource. But those are the things that are recommended. But since they are newer additions to the bundle, we haven't seen the extent to which people are able to do them and what difference it's making.
Great. Well, I'm not seeing any more questions in the chat. Would anyone else on the call like to ask any questions of Dr. Callaghan-Koru?
I was just thinking as you were talking both about this idea that it can take certain hospitals or health systems a longer period of time to kind of get up and running with these things. And I've done quite a bit of quality improvement work within the VA, and I've certainly found that to be true as well. And I almost wonder if there's some kind of like adaptive trial design, which is certainly, not what we're doing here, but if there's some lessons learned from that can then be applied. And as I was thinking this and preparing to ask my question, again, it struck me, right? Who is paying for this, right? Like for your time, for the infrastructure time to provide these tailored supports. And so I wonder if they're kind of future tense, if there are insurance reimbursements or something that can help provide for this, thinking about how do we have these tailored collaborative support, because I think there is something so important about quality improvement and peer support and peer navigation and problem solving that can be really helpful. Anyway, I don't know what thoughts you have on that or how you think about those things and tailoring to the needs of the folks who are further behind while also giving the folks who are further ahead opportunities to move on to other things or help those others.
Yeah, so I think who's paying for it is an important question. And one of the reasons I actually should have talked about that a little bit is that, as I mentioned, the research funding timelines just don't align with real world quality improvement work that moves rather fast. So most of it is paid for through our program grants. So we have, for supporting the Perinatal Quality Collaborative, we have a CDC grant for which is a Perinatal Quality Collaborative specific mechanism. We also have 2 HRSA grants that help support some of the Perinatal Quality Collaborative work. They're both maternal health grants. One is State Maternal Health Innovation Grant, and the other is a new AIM capacity grant, which they gave to a lot of states. And what I have been seeing is a really increasing interest in rigorous evaluation and including implementation science in those program grants, especially our CDC grant. There's a request to include implementation science concepts in the evaluation plans for each PQC, which is great. So I think there's a lot of ability to do this kind of implementation research work within program grants. And for me, there's a lot of satisfaction of having program grants and doing the program work, even though it might take away a bit from my research productivity. It's really rewarding to be working really closely with these hospitals and seeing the real world impact of the work that they're doing. So that's one thing. It's to look at program grants if this is something that you're interested in and would enjoy the more practical side of the work as well. In terms of adaptive approaches, I think that's a really important way to explore going forward, but we're probably not there yet. Being able to assess where hospitals are at the beginning to see what kind of tailored supports they might need is the first thing we need to do, but also figure out how to do tailored supports. And I think the only downside to that is, to what extent are you losing the collaborative model if hospitals are at different timelines?
Great. We have a couple more questions for you in the chat. We spurred some questions. A general implementation science question. Do you have a resource for determining the best framework for a given use case? I have thoughts. Laura Ellen's laughing. Jennifer, what do you think?
So I know that there are others who worked on this, and there are some like online tools for it. And those of you that do implementation science training and implementation science institutes probably have resources that you would go to. I think typically people become familiar with one that feels really comfortable for them in either fit their question into that model or seek out questions that fit that model. But I have switched between different models for different purposes when it seemed like this one works for this question, but that one doesn't. And then I'll share my bias. My personal favorite is the COMBI and the behavior change wheel. I think that that's really useful for most of the research questions that I've explored. But you know, it depends on what your question is, and I don't know if people have a really good experience with tools for selecting models.
I don't have a great experience with tools for selecting models because I find that the tools are just as confusing as the list of models themselves. I tend to think of theories, models, and frameworks as tools, and just like you might have a small set of tools that you use all the time. So you have a screwdriver that you use, a hammer, a wrench, and it's like that's it most of the time. I think most people, like you said, have a very small set of theories, models, and frameworks that they use most of the time. And then occasionally you'll have a use case where those tools aren't serving you, and you may go out and find a different one that applies. But I put the link for a Per Nilsson paper in the chat that I think of as an oldie but a goodie. It's published in 2015, and it's called Making Sense of Implementation Theories, Models, and Frameworks. And it has a taxonomy of theories, models, and frameworks, basically 5 categories. I won't go through them, but I have favorites in each of those 5. So it sort of depends on what the use case is. If I'm doing an evaluation versus if I'm trying to build out a conceptual model versus if I'm thinking about determinants, I sort of have my favorites. But Laura Ellen, I'm sure you are asked this question often.
Yes, and I was asked this question yesterday in a meeting, and it is really hard. And what I try to remind folks is that I will say most of these frameworks are saying mostly the same thing in kind of a different kind of way. So I'm not sure, I don't want to say there's no wrong answer, but we're close to being there's no wrong answer. I do think one thing that might be useful is to think about and look based on your topic, are there other examples of implementation studies within that topic area or within that trial design or whatever you're looking at, and how did they use those? And also thinking about what are the gaps of these frameworks, because there are gaps, and how can we think about critiquing those and advancing the field in that way as well. I see someone has mentioned CFIR. I have a bias towards CFIR, but I have also worked with PRISM Reaim. I've worked with iParis. I've worked with the TIC checklist. I've done some stuff with COMPI. You know, pick which one you like. And I think as long as you can justify it, integrate it, and critique it well, I think for the most part, you're good to go, which is not the answer I think that people most often want to hear. But that's my 2 cents.
No, that was
Inclined to
super
agree.
helpful. Thank you.
Good, good. Rosie is asking if you have any experience with the Evidence Now model from AHRQ.
I don't. Can you share what that is?
Rosie, I don't know if you're able to unmute or if you want to put something in the chat. It's really interesting to, oh, sorry, go ahead, Rosie.
Yeah, I can unmute. Basically, it's a complete model that has the implementation and evidence-based and quality improvement all rolled into one, and it's got a whole host of different tools that they use, but I'm not familiar with any of those, and I'm looking for an expert because I kind of like to use this, and I don't know the best approach because there's so many that's fashioned under the umbrella of Evidence Now.
So I'm not familiar with evidence now. I will say that I think the importance of creating tools that are usable is really key, and that's something that Jennifer spotlighted in her talk. It's something that Julia Moore highlights. She's from the Center for Implementation, which is a company that helps people sort of integrate implementation concepts into their work. But I love a lot of the stuff that AHRQ produces. And at the same time, when you look at it, you're sort of like, okay, now what? And I put Team Steps in that category because I think Team Steps is amazing in terms of content on how to facilitate teamwork. But also there's still a little bit of a gap in terms of how we use it. And it's sort of the gap that Jennifer talked about, sort of parallel gaps. So yeah. Okay, I think that that's it for the questions. So I'll draw us to a close. I'll thank you, Jennifer, for an amazing talk, for talking about some of the synergies and complementary areas between implementation science and quality improvement, and showing how you've highlighted that in maternal health. We're really honored to have had you. Thank you so much for your time.
It was really a great joy to be here and share it with you all. So thank you very much for the opportunity and your attention.
Great, and thanks everybody for coming. We'll see you next time.
Bye.
Bye-bye.